Good morning. I think it's time to get started. My name is Cecilia Rouse. I'm the Dean at the Woodrow Wilson School, and I'm thrilled to have you here today, and I'm very excited to be hosting today's Big Data and Health Implications for New Jersey's Healthcare System. It's a conference that is co-sponsored by the Wilson School Center for Health and Wellbeing and the Nicholson Foundation. Throughout the day, you'll be learning from influential scholars, government officials, private and nonprofit sector leaders about the effects of big data technologies, the effects that they have on our healthcare system. We've assembled 4 impressive panels that will be discussing and exploring big data in the context of health, privacy, cost, and transparency, as well as opportunities and challenges in New Jersey. Our 2 influential keynote speakers will examine how data can transform healthcare and help clinicians improve care and patient outcomes. With me to kick off today's event is Jan Nicholson, president of the Nicholson Foundation. Jan is the director of Ball Corporation and Radiant Group, president of the Grable Foundation, and serves on the board of Public Media Company, the Tri-State Areas Region Plan Association, and we both serve on MDRC's board, which is a social policy research organization. She holds a master's degree in urban planning from New York University. Please join me in welcoming Jan Nicholson.
Thank you, Cece. It's a pleasure to be here with you today. On behalf of the Nicholson Foundation, I thank you and the Woodrow Wilson School for co-sponsoring this conference. For 10 years, the Nicholson Foundation has worked to address the complex needs of vulnerable populations in New Jersey. We've sought to collaborate with other stakeholders to try to transform its health and human service delivery systems. Over the past 5 years, we have increasingly focused our efforts on improving how health care for the underserved is delivered and paid for. One of our first partners as we started down this path was the Camden Coalition of Healthcare Providers. Dr. Jeffrey Brenner, the coalition's founder, is on today's program. Jeff used data from various sources and analyzed it in innovative ways. He made important discoveries that led to the very first application of hotspotting to Medicaid services. This groundbreaking work demonstrates what the careful collection and analysis of data can do in healthcare. Today, we're here to explore how new ways of thinking about and using health-related and other kinds of data can improve the health of New Jersey's residents and communities. As we examine the importance of data in health, our hope is that what we learn today can be applied to advancing the goals of better health, better care, and reduced costs in New Jersey. Of course, the healthcare field has long used data in various ways. What's changing and why this conference is so exciting is that we have entered the age of big data. In the simplest sense, big data refers to the use of extraordinarily large, diverse, and complex data sets that are now collectible, combinable, and accessible with increasingly sophisticated analytic techniques. But in a deeper sense, big data refers to a more fundamental shift in how we use data to give us insight. Now, we can look at the totality of a population and not worry about whether a sample is reliable. We can accept untidiness in the data and not have to waste energy cleaning it up. And in our approach to the information, we cease to postulate about cause and effect. We simply look for correlations. If a person's credit score is the best way to predict whether they will be compliant when they leave the hospital, we should use that to decide when to release them. I believe that big data is going to evolve from its enabling technologies the same way that social networking grew out of communications advances. I think big data's impact on what we can intuit and be guided by will be as momentous in its impact as the impact that Facebook, LinkedIn, Twitter, and YouTube have on how we connect and share. Big data is just behind in its application and in our awareness. There's a continuum. Some profoundly important data analyses simply capitalize on the new availability of data, on the cloud to store it, and on faster computing to parse it. Other analyses are driven by the hunt for correlations. Today, we are capturing all of this under the rubric big data. With careful and informed interpretation and use, big data can help us answer some critical questions in healthcare. For example, what impact does the degree of access to health services have on the health of individuals and communities? How can clinical interventions be targeted and tailored to better meet patients' needs? What is the comparative effectiveness of different providers and interventions in terms of quality and cost? How do social determinants of health correlate with patient adherence to treatment and clinical outcomes? And how can we extract the most benefit from the ever-increasing supply of location-based data? After all, health outcomes are intimately related to where a person lives. Today's conference brings together an extraordinary group of experts, researchers, thought leaders, practitioners, and policymakers. They work in different settings: academic and research institutions, health centers, think tanks, and government. They each bring their own unique and informed perspectives on the opportunities and challenges of big data in health. We'll hear from the nation's first Chief Technology Officer and from a former National Coordinator for Health Information Technology at the U.S. Department of Health and Human Services. We will also hear from the Commissioner of New Jersey's Department of Health. We'll examine the many and varied uses of data, including basic research, personalized medicine, building an all-payer claims database, and ensuring that these insights foster the transformation of current practice. We'll discuss the issue of privacy and explore the challenges of simultaneously sharing and safeguarding personal health information. We'll investigate how data sharing can influence the way we pay for health care as we move toward a payment system that rewards value rather than volume. We'll explore how making data more widely accessible and transparent can enable diverse stakeholders, including consumers, to make wise healthcare decisions based on quality and cost. Finally, we'll hear about some of the exciting ways that data is being used in New Jersey and discuss how we can build on this. The Nicholson Foundation hopes to spark an important conversation that continues long after this conference is over. We are committed to supporting efforts to use data in the service of improving health outcomes for vulnerable populations in this state. Thank you for being here with us today, and I hope you enjoy the conference.
Hey, good morning, all. I'm Maureen Deevey, and I'm with the Nicholson Foundation. And a conference like today with this very rich and somewhat long agenda takes the efforts of a lot of people to put in place. So I wanted to just briefly say a word of appreciation to the Woodrow Wilson School, especially Professor Janet Curry and Elizabeth Donahue and her staff for making today's conference a reality. Also, thanks to the many people who worked with us on a planning work group whose name is listed in your folders today for helping us to get started and helping to shape our agenda today. And a special thanks to Jeff Brown of the New Jersey Institute of Health Quality Institute. Jeff has really been by our side in planning and preparing for today's conference. And now it's my pleasure to introduce our first keynote speaker, Aneesh Chopra. He was the first, as Jan said, he was the first Chief Technology Officer with the federal government, and he was tasked by President Obama to promote technological innovation to help make government more efficient and effective and more transparent. And his leadership on open government data set the stage for a lot of the ideas that we'll be talking about today, and also encouraging the collaboration with public and private sectors. He is the founder and currently the executive vice president of Hunch Analytics, a data analytic firm. And we are honored to have him here today, but we're doubly honored to have his parents join us today. Yeah.
All right.
Watch yourself. And proud parents they are, with good reason. And as Aneesh said as he came in a short while ago, let's have fun. So let's welcome Aneesh, and let's have fun.
Yay, thank you. Very kind. I'm ecstatic to be here. I was born not too far away from here at the Mercer Medical Center, and I was raised in Plainsboro, New Jersey. So I had a great deal of fun volunteering at the Princeton Medical Center when it was over here, as opposed to the fancy new place it's at over there. And so that's why it's exciting to have family join us today. This is an absolutely exciting and ecstatic time to be in healthcare. And I'll share more about that in a minute. Do you need me to do this? You can't hear me? All right, here we go. But I want to begin by asking the question, who's ready for Wednesday? Does anybody knows what's happening on Wednesday? Oh, Wednesday is an exciting day. What's happening on Wednesday? Professor Reinhardt, you might know what's happening on Wednesday.
The exchange is closed.
Oh, the exchange is closed. Yes, no, not, that's one element. No. For those of us data nerds, Wednesday's a big deal. It's the day that CMS releases basically all the files on how they pay doctors in America. For those of you who've been following this story, this is 3 decades in the making. We've had a political debate, policy debate, regulatory debate around whether or not payment information, that is what CMS pays doctors today, is worthy of public availability. There had been court cases going back 30 plus years on whether that is deemed private information on behalf of the doctor, which is your essentially revealing salary information. And after a court recently overturned such ruling and suggested that this information is in fact worthy of public disclosure, CMS went about a process to get public comment, and over the course of the last several months made the determination, announced, I believe, 2 days ago, that Wednesday will be the day. Information on over 880,000 providers, $77 billion worth of expenditure on the types of care being delivered in the doctor's offices, and perhaps most importantly, the number of patients associated with the payments, so you can sort of surmise service intensity and a variety of other factors. Truthfully, the news media will likely highlight the extremes that will show up in the data, no doubt. The doctor that miraculously seems to be working 30 hours a day because there's no other way to get to that volume of care. You're going to see a lot of this mess in the data. But even beyond the kind of salaciousness that you'll likely find in the news, there will be a more thoughtful understanding about the practice of medicine, the variability of medicine. And I think the reason I joked about nerds having fun is CMS has made the judgment that that data should be made in machine-readable form in bulk on day 1, which is on Wednesday. So have at it, entrepreneurs and innovators. See what you might mash that data up with. By the way, the screenshot is not actually of the visual of that particular data set. That just happens to be an example done very early in the Obama administration to begin shining light on its operating performance. By the way, one interesting sidebar, getting into the implications for other entities, to give you the understanding of the importance of data into the organization, CMS has actually reorganized its internal chain of command. There is now an executive responsible for information products that has a direct line of reporting up to the administrator. And I say that because we're going to get into some of the bureaucratic and organizational needs to support this new big data economy, and one of them is to treat data as an asset, not only its primary use, but its reuse, and we're going to talk more about that throughout the morning. So what of this big data revolution in healthcare? Our friends at McKinsey in the fall of last year had done a study that the opening up of data, and I missed over the title slide of my remarks, by the way. I have an appendix to the purpose of the meeting today that while I'm excited about big data, I'm equally excited about small but open data. Small but open, and I emphasize the open, because our healthcare system is nothing but fraught with silos of data that may not be the kind of clickstream internet information source that's been the heart of big data today, but is very important to have open. Opening up of data, according to McKinsey, will unleash a $3 to $5 trillion economy, improvement in economic value. And if you drill down, healthcare itself, just in the United States, accounts for between $300 and $450 billion a year of value. There's an MIT study that suggests that the key benefit of data-driven analysis is that it boosts productivity anywhere from 5% to 6%, very critical to happen in these regulated sectors of the economy. So I said at the outset that there's never been a better time to be an innovator in healthcare than right now. Why are we so bullish on this decade? For the politicians, it's an excitement around the ACA, and I'm very excited about the ACA. But in a broader sense, there are a few key trends or regulatory pathways that are available to us today that were not available to us yesterday. First, the opening up of data. This comes in two forms. One, we are digitizing that which used to be on paper. You'll hear from Farzad about the progress, the remarkable progress that we've made on that journey. And then second, once we've digitized, we've now made that information open. Information liberation is a central part of the thesis. But it's not sufficient. You heard Jan mention this in her remarks, pay for value over volume. The change in payment incentives, I humbly believe, is the single most important change to drive the business case, if you will, for big data and big data related applications. And here's the most important point. Payment reform isn't only the domain of the elites telling us what will happen, like some proverbial Moses with tablets, but is an opportunity for us at the state and local levels to design the payment models we wish. I will come back to that very, very important principle because I don't know how often that's been part of the debate, but I'll come back to it because it's critical in determining why this is the best time to be an innovator and why I believe the combination of these forces are leading for rocket fuel. Now, I'd like to put this in some historical context just to ground us a little bit. I am a Virginian now, although I was born a New Jerseyite. I am a Virginian, which means I pay homage to Mr. Jefferson. And it turns out that Mr. Jefferson was an open government innovator before it was cool to be one. You see, Mr. Jefferson was a bit of a weather nut. He was absolutely, not dogmatic may not be the right word, but religious in his zeal to collect weather information at every moment in time, two or three values a day. And on this particular day, you might remember that it has some significance to the country, on July 4th, 1776, what you found with Mr. Jefferson was a man who walked into a local shopkeeper in Philadelphia, purchased some equipment in order to measure the fact that it was mild on that particular day with a high of 76 degrees. Now, I mention weather because part of his challenge when he was president to Lewis and Clark was on their expedition, they were to collect data and to make it available to the American people. Now, fast forward the spirit of Mr. Jefferson and ask yourselves how today's weather economy operates. It's at least a $5 billion a year service economy, but nearly all of the data that informs that commercial enterprise, the weather industry, is derived from the National Oceanic and Atmospheric Administration, the federal agency that is responsible for collecting satellite data, sensors data on weather conditions, has decided to make that information freely available without intellectual property constraint to any entrepreneur, innovator, company, nonprofit, charity, you name it. So, entrepreneurs in the big data sense that formed a company called Climate Corporation, like 30-plus engineers, thought that they could take weather data and other open government data, apply newer techniques in analyzing that data to build a new concept, a new product around crop insurance. It was so successful, Monsanto recently acquired this 30-plus person company for $1 billion. $1 billion. Now, it would have been commercialized at Ed Felton's shop had his team been on this problem. Right, Ed? Yes, of course. Now, the point is, the level of entrepreneurial activity is picking up pace, and a great deal of that activity is consuming information that's been made available by the public. But in healthcare, the litany of open data sources is just getting started, and it's growing exponentially. I've mentioned government spending already in that CMS filing, but we've been releasing spending data now in CMS for quite some time. I'd like to share a few other anecdotes as to how data that's been made open in combination with other data sets has led to economic and clinical value. First, one of our favorite case studies is the story of eye triage. An emergency room doctor, entrepreneur in Colorado, came to visit me at the White House early in the first term of the Obama administration. I wasn't quite sure what to make of the meeting, to be honest with you, because the way it came about was he had asked his senator Michael Bennett to write me a letter to take the meeting. And that usually means that there's some big ask coming. You know, this person asked his senator to call a meeting with me, so I'm like, okay, what's he looking for? So we have a very brief meeting, and it turns out that his ask was quite simple. It was to help understand all the new open data sources that he could incorporate into his iTriage app. Millions of Americans were downloading this service to figure out whether they should go to the emergency room or not. And it turns out that one of the data sets that we kind of made recently available in machine-readable form was a list of all the federally qualified health centers in the country, geolocated. Now, mind you, these clinics are cost-effective, but they lack any kind of marketing budget. So they're not like advertising on TV or buying internet ads on Facebook. So it's not that easy for them to get attention. But the data about where they're located was publicly available. So the entrepreneur incorporated that information into the app, and without any fanfare, over the first year in which he'd incorporated this data set, basically if you say, don't go to the ER, let me pop up a location, a set of nearby clinics that you might visit instead, he generated over 100,000 referrals to low-cost, federally qualified health centers. No cost to the taxpayer, no cost to the clinic, just a more contextually relevant service because he incorporated open data into his iTriage application. I'm going to skip Blue Button for a moment. I want to come back to it. But we're starting to see much more interesting use of consumer product safety data, Fda Recalls Data. You know, in the old days, you'd have to visit the FDA website to keep a list of where all of the recalls were coming out. Now, entrepreneurs and innovators have flipped the model. Because we've made that data open, they can set alerts. So I no longer have to be daily, you know, no one really does this, but in theory, go visit the website every day to see, is the drug I'm on been recalled? Instead now, entrepreneurs can provide those alerts to you. Just sort of enter the drugs that you're on, and it'll just work in the background. And if there's ever been an update, you'll get pinged right away. Entrepreneurs are building products and services around that. Medical students at Johns Hopkins decided to come up with a probabilistic algorithm to help you determine your diagnosis. So they used a very interesting way of leveraging the National Library of Medicine's assets, such that if you've thought you've got appendicitis and the patient's wondering what is an appendicitis, when you click on that link, it takes you to the National Library of Medicine's summary definition of what that diagnosis means. So at no cost to you and no cost to the entrepreneur, you can provide peer-reviewed, clinically relevant information delivered directly on the phone to a consumer. In this case, they built this over the course of a few days. And to the point Jan mentioned at the outset in terms of new models of public health, one of my personal favorites is the story of what was then called Asmopolis. Now, because it's been venture-backed, it's got a better, more fancy name called Propeller Health. The story of my friend David von Sickle. David's kind of a public health researcher at heart, and he thought that asthma is really an information problem as much as it is a chemical one for the lungs. And what he meant by that was, if we could figure out the environmental circumstances that triggered an attack, we might be able to treat the conditions more holistically. So what he decided to do is take it, the most exciting source of open data, we all have it in our phones, that GPS chip. You could thank Uncle Sam because we fund the satellites that allow us to have that GPS chip on our phone. So what David had done was he applied a very modest GPS addition to the asthma inhaler. So anytime the patient inhales, it records the time and the location. He then aggregates that data for users in a community. The mayor of Louisville, Kentucky ran a trial to understand whether or not his environmental staff could be better deployed based on the evidence of where people have asthma attacks. And exactly as we would anticipate, they took the data, identified certain areas in the community where they had higher share of whatever that particulate matter is that's causing asthma, 2.5 or whatever that is, and they put more, they didn't add resources because we're in a budget-constrained world. Government's not spending more money, but they're redeploying and focusing their efforts where there's problems, and they were able to cut particulate matter in those high-concentrated areas something like 20+%, just because they had the data and they could act. the spirit of public health and collaboration. And I want to make it very clear to you from a mathematical standpoint, the value of data isn't the source, like one source itself. It's, hey, this is a GPS source. It's the mashup of multiple sources. And my proposition to you today is that adding one more data source on your proprietary data source doesn't create value in a linear fashion, but actually creates value in an exponential fashion. So keep thinking about ways you can enhance or enrich your data with external data that now is increasingly open. But I want to dial deep on this idea of permission-based data, because I'm going to come back to this around the privacy implications later today. It is my hypothesis that the way around this privacy conundrum, I've been in public service now for about 8 years, and what was fascinating to me was this very, very odd trade-off. Give away your privacy rights in order for us to do better health care. And why can't you just give up your rights? And sort of there's this, why can't we all move to an opt-out culture? Or why can't we just make the data available and just tell people it's good for them? All of the dialogue around health information exchange and opening up information always started with the premise that somehow we would have to make it one gives and one benefits. So we'd lose privacy in order to gain insight. I suggest to you that that is a false choice. That in fact, the most powerful weapon in opening up data is engaging the consumer themselves. Long before a hospital cuts a deal with a pharmacy company to have patient data shared between the two organizations, with or without privacy protection, what we know today is that every pharmacy in America has agreed, everyone, that is the large ones, 150 million Americans who visit pharmacies, can access their pharmacy prescription history data in machine-readable form directly to themselves. This is a screenshot from Walgreens. You can see at the upper left. Right now, as we speak, a patient can keep a list of all of their prescriptions purchased from Walgreens. And while they may not want to log into this and have fun playing around with that data set, because maybe that's not what they are particularly interested in doing, they can delegate that to a Dr. Brenner in Camden, for example, and to say, hey, I'd like you to have access to my prescription history so that if I didn't actually pick up the med that was ordered by me, and so you can reach out and help me stay compliant or adherent. Payers. Medicare, now 3 years in, has been giving patients the ability to download their own Medicare file with 3 years of history. How many of you are on Medicare today? Anyone in the room on Medicare today? A few, couple, one or two? And sir, have you accessed your Blue Button file? No. Out of the 30 million Americans that are on Blue Button, very, very few, perhaps a point or two, have actually created a Blue Button account. My dad did. I was home in Jersey, and I said, Dad, I want the Blue Button file. It took us about 2 minutes to set up the account, but I now have my dad's Blue Button records on my phone, which includes the providers that he'd seen in case I need to reach them, God forbid, if anything happens. Free. Lab companies are now, by regulation, opening up such data, as are the electronic health records companies. More on that from Farzad when he talks about meaningful use. But the opening up of this data isn't necessarily going to lead to the production of new products and services. You need to have a business model. And I believe that payment reform is the key to making this work. So you can take a look at all of the rules that were in the Affordable Care Act, and I've listed a bunch of them. In the law, we're going to move to medical homes, we're going to create ACOs, we're going to redesign bundled payments. All of this is interesting, and I suggest to you that there's a set of analytics that are going to be necessary in order to deliver against these new services. But New Jerseyans, I suggest to you one more important point that's not on the slide. In the Affordable Care Act, HHS has the full authority to test any payment model it chooses. And if the actuary of HHS certifies that whatever that payment model test is achieves quality and cost improvement, upon certification from the actuary, the Secretary of HHS can promulgate via regulation and without going to Congress the ability for that payment model to be available to the country. So right here on this day, when you break out in a meeting, you might design a new payment bundle. I have one that I'd love to see birthed, bundles for babies. In Virginia, we have a third world country infant mortality rate. There are pockets of Virginia that have no high-risk OBGYNs. We did a pilot when I was in the governor's office where we funded UVA to provide essentially telemedicine consults. So a high-risk OB at UVA would beam into a federally qualified clinic in the Shenandoah Valley, and we cut preterm birth rates 25% by providing access. Today, there's no reimbursement model for that use case. But if we created a bundle where at that first check-in, the pregnant mom at 12 weeks, we screen them and say, geez, you're a high-risk candidate. We're going to give you a bundled payment to the providers, and we're going to allow them to do things like the high-risk OB, telemedicine in, smart video chatting on your cell phone, whatever the case may be, so we're going to get better outcomes. That case study of what I've funded goes away if there's no reimbursement for it, even though it cut preterm birth 25%. All right. A few thoughts about applications of big data, just so you can whet the appetite about what is this phenomenon. On the one hand, a key aspect of big data is simply visualization. And so here's an example. If you wanted to understand all of the comparative effectiveness studies that have been funded by the government and for which there are peer-reviewed literature in the National Library of Medicine, this gives you a sense of not only where are the studies, who's funding them, and more importantly, where have they been citations and linkages between them. This kind of visualization takes the National Library of Medicine's sort of file cabinet of articles and gives you contextually relevant information so that you can determine, maybe I want to support that professor to do a study because they're onto something that's adjacent to where I want more insight coming. So visualizing large sets of data is an important application in big data. Perhaps a more interesting and awkward one is for my friends in Silicon Valley. They joke about the fact that at this time in America, the very best engineers are designing, and I hate to say this because it's sort of an embarrassing way of describing it, but they're designing new sexting apps or whatever on Snapchat or whatever these things are, because that's where they're getting the social media, the big data, the streams of information on which they can run these new applications. I believe you're going to see a new model where that kind of marketing and analytic capability in the retailing environment will come to healthcare. And here's just a couple of examples. We've just gone through this enrollment experience. I asked the guys at Enroll America, who's the most successful source of emails of people interested in buying health insurance? Anybody know? You could tell by looking at the screen. The answer was Pandora. Who would have thought that a music app would be a really easy way of engaging people who want to buy health insurance? And it turns out that it's such an easy way when you're listening on the mobile app that 2 clicks and you can send your email address to Enroll America and they can contact you to figure out whether or not you want health care. So now I'm not saying, I'm not here to plug one company over another, but my simple point is that applying the kind of marketing and analytics techniques that are being used to get you to buy a widget are now going to help you make better healthcare choices. You know, a lot of what you guys will talk about today in healthcare is not necessarily the patients come to a healthcare provider and they're getting bad care, although there's some of that for sure. I think a bigger problem is they're not coming in to get care when they're supposed to, and it's the missed opportunity, in a sense, a marketing opportunity fail that is the biggest issue. Oscar is a startup health insurance plan that's built entirely for the exchanges. And I had a wonderful dinner with the CEO, and I tried to get my arms around what was new about the Oscar experience. You're a startup, you're all these tech guys, what makes you different than all the insurance companies? First, there were 2 things he said to me that blew my mind. Number 1, 2 weeks in, so January 15th, 65% of the newly enrolled patients had already accessed a service or given clinical or health information to Oscar. Why? By design. they marketed heavily free telemedicine consults. They told people, look, as soon as you get insurance, have a quick consult with the doc over your phone or on some other digital device. So we get a smarter baseline as to who you are and whether or not we need to put you in a high-risk bucket, a low-risk bucket, or whether we want to coordinate your care. 65% shared their health information in 2 weeks. For my friends in the health plan industry, what percentage of patients fill out their health risk assessment? Yeah, exactly. Second insight that was powerful is they turned the flat file provider directory into a dynamically generated recommendations engine. And they're just getting started. So it's not perfect today, but here when you click on their recommendations for doctors, you could see on the screenshot, patients my age, tell me which doctors they see. And that's just the beginning. What we're going to see in the future is patients with my medical conditions, which doctors do they see to get the best outcomes, right? I don't want managed care to tell me you're in or out of network in a crude, clumsy way, but if I trust the service that's going to provide for me recommendations based on the data, I believe that is a huge new area where the application of big data will make a difference. And then for my machine learning friends who love playing with unstructured data, I want to share with you the story of a research team at Stanford that took the medical notes in the electronic medical records. This is the stuff that's not necessarily easy to compute against. It's just raw blobs of text. And by analyzing the notes across Stanford's population, that's one hospital, mind you, one hospital, not the research side, the operational hospital side. They were able to identify Vioxx 2 years earlier than the regulators. They then looked at all these other recalls and identified for 6 out of the 9 drugs that were recalled over the last decade, just analyzing one hospital's notes was enough to give them an early warning indication. So it's an important point to understand that big data means it's also lots of variety of the data. In this case, clinical notes. Here's why I bring it up. When you talk to the HIE people in the state, when they come up here and talk about health information exchange, they're going to talk about all the fancy things that they're making available with the gajillions of dollars the feds gave them. Ask them if medical notes are in the list. And the answer is going to be obvious. No. So we're in the early days of this big data revolution. There's a heightened investor interest and a policy interest. You can sort of see this conceptual framework that says we're on the very early days of the publication of all of this data. A few case examples of my friends. Ginger.io. Ginger.io is a sort of a spin-off out of MIT. These kids have found a way to take all the data on your phone, who you call, where you walk, what you do, and they're able to deduce your mental state. If you're depressed, if there's a concern. So just passively collecting all of this information sets triggers and alerts that would tell your caregiver that they should reach out before things go south. Wow. Interesting. Blue Star, which is actually WellDoc, the very first prescription for a digital service. Think about this for a minute. We think of prescriptions as a pill. WellDoc said, we've got this mobile app that would allow you to, essentially behavioral economics, right? We're going to nudge you into eating better and keeping, watching your weight and managing your blood pressure and the like. For diabetes patients in their clinical trial, engaging with the WellDoc platform had essentially a 4-fold improvement over a pill intervention when it came to managing A1C levels for diabetics. So they got peer-reviewed. They got approved for drugs. So a doctor today could have a prescription pad and can order 1 month of cell phone therapy. And they're going to get paid a healthy penny for it, Uwe. But here's the interesting point. They've opened up the floodgates. All the data they're generating, interacting with patients, medical records today are infinitesimally small data. You might see a doctor once a year, and they might have just a little bit of information about you. But if you're interacting every single day with your digital service, your WellDoc app, you're producing an enormous amount of data. So where is it getting stored? Punchline, it isn't the EHR. Last but not least, my buddy invented this patch, Dr. Uday Kumar. It's called the Zeo patch. So if those of you have ever had to go through a Holter monitor stress test, you have to sit there with all these leads on your body, and it's sort of uncomfortable. So what he invented was a patch that you put on your skin, and you can just walk around for 2 weeks, and it measures your heart rhythm. And a great deal of the patients that have been on the patch actually have an arrhythmia, which means you want to treat this before something bad happens. And again, 2 weeks of heart monitoring data, how much of that is in the EHR? I asked Uday, how do people store this data today? He says, he's sort of jokingly, they sort of scan in my report and attach that as a document into the EHR, not the raw data that you'd want to compute against. So we've got to get our arms around how we think about new repositories of data. But last few points before you move on in the day. It is an interesting conversation to be had about the role of privacy policy in healthcare. And I think we've been asking the privacy question the wrong way. We've been focused on consent and authorization. And in healthcare, it's like get them to sign a form. Has anyone ever really read the consent forms? So the notion that somehow you've actually given them protections on their privacy and honored their intentions, give me a break. President Obama unveiled a Consumer Internet Privacy Bill of Rights that had to do with the broader internet economy. By the way, shout out to Ed Felton again for his leadership on this issue, Godfather. And the idea, among the many ideas in the Bill of Rights, is that we should move from a model of authorizations, signing a 50-page form with 6-point font, to control. Give me a control panel. Give me a settings panel. So I may allow Netflix and Apple TV to interconnect, and I do that using OAuth. But if I'm ever unhappy with my Apple TV, I can always log in to netflix.com/settings, and I can depermission Apple TV from accessing my history. We don't do that in healthcare. Now, it's interesting. If we started to, new business models emerge. CVS will pay you up to $50 for your data. What? Last year, CVS said, we're going to create a new rewards card focused on your pharmaceutical history. If you give us permission to use your pharmacy history with us to communicate back to you, we'll pay you $5 for every 10 prescriptions you fill. Wow. Paying people for data. Creepy, maybe. Exciting and interesting, certainly. And they've given you a digital opt-out. Now, I shame my hospital friends because in the Medicare ACO program, where they get all the Medicare claims history for every patient, we made the policy decision to make that opt-out. So for the 5 million Medicare beneficiaries who are in an ACO, your medical data is going to the doctor. You have the ability to opt out, but if you go to a hospital's website, I challenge you to go to a hospital's website. It says, call 1-800-MEDICARE or write us a letter to opt out. Ed Felton, is that sufficient? No. The basic principle is you should make it as easy to opt out as it is to opt in. And what CVS has done is, even though they're kind of getting creepy on the asking you for your data, they're giving you an opt-out online. Final point, and this is critical, because we are stakeholders in this important industry and we've got to change. But I want to begin by saying, are you Kodak? Do you know the story of Kodak? One of the nation's most important entrepreneurial firms. They had like a monopoly position on everything in the film business. They could do no wrong in the 70s and 80s. My goodness, they invented the VCR. But they chose not to commercialize it because they didn't believe any of you would pay $500 for it. They invented digital photography, but they failed to commercialize it because they thought it would be too disruptive to their core business. We have too many Kodaks in our economy who fail to properly manage an innovation pipeline to bring new products and services to life. And the challenge in healthcare is whether or not our fate will be sealed as Kodaks. It was such a bitter irony that in the State of the Union 2012, our guest that year was the co-founder of Instagram. Now, the reason was because he's a Brazilian immigrant, and we think that America's immigration policy is just ridiculous and stupid, and we're kicking out these brilliant people who shouldn't. So we wanted to have this wonderfully successful entrepreneur in the First Lady's box. But at the time he's showing up, Kodak is announcing that it's going bankrupt. And these guys get bought for $1 billion. So I ask these 3 questions for you today. What is the inherent value of the data that we hold? Before we get into big data, each of us in this audience and the stakeholders we represent, they have small data, but they have it in their own way. What is the value of that data? Are we willing to open it up and allow it to be mashed up in new ways with some of these emerging sources of data to create value? Do we pursue an open or closed strategy to unlock it? And are we effectively managing an innovation pipeline? Just think for the moment. I told you that Medicare has given patients access to their claims file for 3 years, and they launched it in 2011. Who's here from the New Jersey government or the Medicaid Department of New Jersey? When have you released your Blue Button file? We did it 3 years ago. Where are you?
Far, far behind.
Yes. But here's the interesting point. The budget to do this is infinitesimally small. This is not a bajillion-dollar project to give people their own data. So, I suggest to you, this is the best time to be in healthcare. This decade, entrepreneurs and innovators are going to fix this problem. We're going to look back and say, man, Uwe, all your analytics and your studies and the future of healthcare, we're going to look back and say, victory! And victory will come because we shed our constraints, we've managed innovation in a more thoughtful way, and it'll be because you are working together to make it happen. Thank you. We started late, but we want to stay on schedule. But if you have a couple questions, I'm happy to take any. Happy to dialogue a bit, whatever makes sense, and then we can get you back on schedule. Yes, sir. No question. Any question? Yes, sir. Tell us your name.
What is going on in healthcare that's learning from a lot of the other industries that have obviously used big data, for 20 years practically? Can you give us some insight on that? I mean, if there's a learning curve, if there's a think tank, if there's lessons learned.
Well, I would say to you, the 80-20 rule for me is unleashing the business, not so much answering complicated questions about the tech or how to get it right. And I don't mean that to be dismissive of the tech. I think the tech is important, and there will be lessons learned about should we put it in the Hadoop cluster, and what's the most efficient way of developing path analyses to determine what probability is this patient going to get a better outcome. All of that is interesting. But it is irrelevant if there is no business case for doing so. So my humble suggestion is that the think tank we need is the think tank to find new payment models that we want to embrace that will unleash very specific applications of big data. Because once you've got everybody incentivized, then you'll be able to find ways to cut deals and to bring the data in. This is not a technical problem for healthcare. I know you think it will be, and that's sort of a debate for the discussion here. It is, that is a solvable problem. It's the payment model that needs the creativity and the think tankiness more than how do we design the Hadoop cluster. Yes, sir.
I'm Dave Nicholson.
Thank you, Dave.
I'm interested in your concept of moving from authorization to control.
Yes, sir.
And I think an area where that's desperately needed is in informed consent.
Yes.
Have you heard of anything that is dealing with that issue? The concept that
Yes.
could make an intelligent decision in consenting, which we do a terrible job. If you want to talk about a ridiculous form that nobody understands, everybody signs, and it's not empowered at all. We wanted budget.
We definitely need more designers to think about ways that that conversation can be had in a trusted way. You have Godfather Felton, who I think could bring you a lot of perspective about how to think about privacy control settings. My instinct is that it sounds silly, but actually Facebook got some of this right. Ed, tell me if I'm wrong here. But we're not unhappy with Facebook's control panel. So I mean, people have lots of opinions about whether Facebook's good or bad on your privacy, but the reality is they have a privacy panel. You log in, and you can, at a very granular level, not only determine what content source you're willing to share, but with whom and at what level. So it might be the case that we have these digital services. The default is that you're sharing with the doctor that's asking you to sign in. But then as long as they have the ability with ease to opt out, then I think we'll be in better stead. This is engaging the design community. When Farzad's here, he'll tell you that we launched a Blue Button Challenge called the Redesigning the Medical Record, which includes how do you think about the control panel for privacy. A lot of that design work is open source, so that there is work that you can build off of. But I do think that that's the key. Yes, ma'am, last one.
In areas where they haven't chosen the path around Medicaid expansion, they have.
Like my home state of Virginia, which is ridiculous.
Yep, and they have state initiatives or regional initiatives around health information exchange, data sharing. Where do you see the role for that incentive, maybe public foundation funding or other types of funding? You know, are you touching on that? Because without the incentive dollars, you know, you stated it very clearly. Without incentive dollars to motivate this, even if you have a business model, you don't have the funding structure.
So there's two funding structures, and I think for the foundations in the room trying to figure out where to allocate your capital, you face two choices. Subsidize something that will probably never scale, or invest in something that could actually change and solve the game. Here is my humble opinion. I would invest a lot more in making sure that every data holder gives their data to the patient and facilitate the patient being able to share that data with whomever they trust. The Netflix, Apple TV interface, it works. We do have a model of informed, trusted sharing of data, but we don't do it as much in healthcare. So I would spend more money on making sure every data holder gives the data to the patient. We'll sort out whether the patient wants to share it and whether people want to encourage them to give it to them. Let me give you one small example. It may be the case, even without Medicaid expansion dollars, that what is it, Horizon Blues? The Blues might want to cut a risk deal with a provider network, call it Capital Health System, Princeton, what have you. And let's just, for the sake of discussion, in that deal, one of the things that they want to do is reduce the additional cost burden in the emergency room, just for the sake of discussion. It might be the case that the most important information exchange that could happen is that when the patient shows up in the ER and they swipe their Blue Cross card, that data be immediately routed to the physician network that's their care manager, and that they might dispatch someone to join with the patient in the ER to help decide, does this person need to be admitted? Can we bring them back to our setting of care where they have a broader outpatient service setting? Can we do more to inflect the cost, the intensity of that experience by having access to that real-time data? You don't need a PhD in physics to take a very small bit of data, which is the HIPAA transaction eligibility verification, the 270, 271, route that to the doctor's office. That's infinitesimally small data, but what we don't have is the right privacy framework and the mechanism to say, hey, does the patient need to authorize my does the fact that I'm in this ER, does the patient want that to be given to their primary care doc? Figuring out that informed consent model, that easy routing of the data is the most important thing. They're not whether Medicaid expansion happens or we double down on the HIE, because that's the use case we're trying to solve. Okay, I'm in overtime. Thank you all very much, and good luck today.